for the lecture is Adult Orthodontics. The contents in which I'm going to discuss the whole topic is introduction, adult treatment objectives, comparison between the adolescent and the adults, classification, types of adult orthodontic treatment, adult patient management, and conclusion. The introduction. During past 20 years, there has been an increased number of adults seeking orthodontic treatment. In 1971, Levitt stated that the number of adults over 21 years of age undergoing orthodontic treatment would be double during 1980s. Before 1970, approximately 5% of American orthodontic patients were adult. By 1980s, it was estimated to account 20 to 25% of the orthodontic patient, almost 4 times the 71 data. Now, Khanna and Horrocks in 1991 stated that the increased demand of orthodontic treatment by adults could be attributed to improved dental services and a greater dental awareness among the adult patients. The increased demand of the orthodontic surfaces has been stimulated by the introduction of a new aesthetic appliances. Meant to improve aesthetics. Other reasons for orthodontic treatment in cases with certain relapses, progressive occlusal and aesthetic problems that are age-related, lack of motivation and funds for the treatment in the childhood and adolescence, referral for the treatment in conjunction with the restorative procedures. Adult orthodontic treatment objectives are typically applied to the adolescent orthodontic treatment objectives of dentofacial aesthetics, stomatognathing function, like there is a premature contacts or static and the dynamic class 1 occlusion may not be realistic or necessary in all adult patients. Additional adult orthodontic treatment objectives are parallelism of the abutment teeth as demanded by the prosthodontist for rehabilitating the patient, most favorable distribution of the teeth. Yeah, you want to abolish certain crowding and adjusting the space, redistribution of the occlusal and incisor forces, adequate embrasure spaces and the proper tooth position, acceptable occlusal plane, and potential of incisal guidance at a satisfactory vertical dimension. Adequate occlusal landmark relationship, better lip competency and support, improved crown root ratio, improvement of the self-correction of the mucogingival problems and the osseous defects. Say many a times the cause of the infrabony pocket is the premature contacts, and these premature contacts lead into the increased amount of forces at one angle or one side of the tooth, leading into the loss of the bone or a vertical bone defect, and that can be corrected by aligning the teeth and thereby followed by the periodontal surgery. Improved self-maintenance of the periodontal health, aesthetics and the functional improvement. So these are some of the examples. You can see that their pathological migration and a long-standing extraction zone, and treated, this particular tooth, if treated, will be too broad and there is less space in the pontic. It is the space has been this incline has been treated. This tooth has been pushed initially and this is pushed distally, leading into the alignment. Now a perfect abutment has been space for the pontic has been created, and a rehabilitation can be done. Like in this case, you can see that the distal pathological migration of the premolars and the mesial migration of the molar has led into the loss of the space. Here in this X-ray, you can see that this is an infrabony pocket. We need due to mesial tilting of the molar in the long-standing extraction zone. After uprighting, a bridge has been fabricated and rehabilitation can be achieved. Again, a long-standing extraction leading into the supra-eruption of the buccal segment or premolar and the molar, and a deep overbite, pathological migration, again leading into the increase in the height of the one inside to 1-1 and less in the 2-1. Same, you can see the deep traumatic overbite all over. For the traumatic overbite, a bite plane has been given, and intrusion of the incisors or the buccal segment can be done by fixed orthodontics, and thereby rehabilitation can be performed with a bite from here till here. You see a significant amount of difference in the occlusion. Again, we can have another case for this. Rather, it is a follow-up of the last case. You can see the better occlusion this time. Another case. We can see a crossbite in this case. Here, the crossbite has been relieved, bite has been jumped, and that is rehabilitated by the bridge. In the buccal segment, you can see the mesial migration, the periodontally compromised zone, the teeth are uprighted, the space, this uprighting has been done by the fixer arches, and thereby we can visualize the parallelism attained by the, in this case. Again, the supra-eruption of a molar, intrusion of a molar attained, and a perfect rehabilitation, prosthetic rehabilitation has been done. Now, the difference between the adolescent and the adult patient. Adolescent patient has a growth potential. A growth modification is possible. No growth is possible. The correction is limited to the tooth movement. TMJ adaptability in the adolescent patient is good, and frequently, whereas the adult patient frequently see the TMJ dysfunction. Periodontal problems rarely show symptoms of the periodontal disease, whereas predominantly you will see most of the adult cases have some other the periodontal problems, which is frequently encountered. General health is really consideration, might be a major consideration in the adult patients, especially if the surgery is planned. Appliance aesthetic is rarely a concern. Children do not bother about the appliance of the major. It is a major concern for the patients, for the adult patients. Retention is usually short term with a removable appliances, and usually in the adult cases it is fixed and it is long term. Appliance tolerance is usually well tolerated and get used to orthodontic appliances very soon. More time is required to get accustomed in the adult cases to the appliance. Speech is adjusted quickly, and the adjustment in the adult patient takes a lot of time and effort. Motivation and cooperation ranges from poor to excellent, but the adult patients are usually pre-motivated and they are very cooperative as far as once they make up their mind. Treatment appreciation ranges from hardly concerned to very appreciative, but the adult patient is usually very appreciative and are very good practice builders. Classification of the adult patients are in the rehabilitative phases. They can have a class A, that is minor orthodontic, class B, that is minor orthodontics with prosthetic restoration, Class C is a major orthodontics, and Class D is a major orthodontics with prosthetic restoration. In the maintenance phase, it can have an orthodontic retention, or it can have a temporary splinting, or we can give some permanent splinting depending upon the incisal guidance, achievable incisal guidance. The types of adult orthodontics are adjunctive therapy and a comprehensive treatment. Goal are to facilitate the disease control and to achieve the ideal occlusion. Many periodontal condition, there we need an adjunctive orthodontic therapy to have a better results for the periodontal therapy and the restoration of the function. Adjunctive therapy is performed by the general dentist and orthodontist, whereas a comprehensive treatment is always being performed by an orthodontist. Extent of the appliance is less than full arch. In adjunctive therapies, we can work on one quadrant, and a comprehensive orthodontic treatment where the occlusion has to be sent, the plane of the occlusion is to be considered, where alteration has to be needed is in canting, has to be corrected. One or both the arches has to be taken into consideration, and that has to be done strictly by an orthodontist. Time frame 6 months or longer in adjunctive therapy. It takes 8 to 36 months, that is 3 years in a comprehensive orthodontic treatment. The types of problems is usually an extrusion or a pathological migration into a space, into an extraction space, and a comprehensive treatment needs is usually needed in an open bite where there's a lot of lips complained by the patient. And molar uprighting has been done in adjunctive therapy, and in debite cases we need a comprehensive treatment. The space redistribution is a type of a problem where we need an adjunctive therapy treatment, and incisor alignment where we need an adjunctive treatment that is a short term. Whereas in a comprehensive treatment, we need, apart from open bite and a deep bite, we need a class 2 or class 3 malocclusion, or where it can be purely for the orthodontic reason, or it can be for the orthodontic and orthodontic followed by an orthognathic surgery. Now, there is a skeletal excesses or deficiency. It always need an surgical intervention. So orthodontics as a pre and post surgical consideration is always taken into a treatment option in a comprehensive treatment plan. Biomechanical consideration, characteristic of orthodontic appliances. For adjunctive orthodontic therapy, 0 to 2 slots edgewise appliances is generally recommended. The larger the slot size allows the use of a stabilizing wire that is somewhat more stiffer. The removable appliances may have an advantage over a fixed appliance in some patients with a multiple missing teeth. If many teeth are missing, this approach may be the only way to generate the sufficient anchorage, because there we are having generating the anchorage from the tissues apart from the teeth. Though nowadays the implants have been used for effectively for this purpose. A partial fixed appliance for the orthodontic treatment, the bracket are placed in an ideal position only on the teeth to be moved, and the remaining teeth to be incorporated in the anchor system are bracketed so that the archwire slot is closely aligned. We don't want to disturb the well aligned or the anchor teeth. So we do not have to put in a perfect or ideal alignment of the brackets. This allows the anchor system of the wire to be engaged passively in the bracket with a little bending, and the passive engage thereby less amount of forces and to be transmitted to the periodontally compromised or a compromised teeth. Passive engagement of the wire to the anchor teeth produce a minimal disturbance of the teeth that are physiologically in the satisfactory position. Now here we can see that we have not we want to upright the premolars, but here we are not desiring for an uprighting. We want that the bracket should be parallel to each other. So the bracket parallelism is more important than the tooth root parallelism in this case, as been described here. Effect of reduced periodontal support. When the bone has been lost, the PDL area decreases, and the same forces against the crown produces a greater pressure in the PDL of a periodontally compromised tooth than a normal supported one. The absolute magnitude of the force used to move the teeth must be reduced when the periodontal support has been lost. In addition, the greater loss of the attachment, the smaller the area of the supported root, and further apical center of resistance will be. That is, the center resistance, to have a recap, is actually between the root, the in the root, and that too in the midway of the bone which is supporting the root. So the bone is more important, supporting this effect moment created by the force applied to the crown and the moments needed to control the root movement. Now here I'm going to diagrammatically explain you what exactly we meant. Now the center of rotation, center resistance of a tooth in an ideal tooth with a good bone height is somewhere here. Whereas as the bone reduces, it will be in the midway from here till the apical zone, and it is somewhere here. Now, since the distance between the center resistance to the force application is say 10, suppose it is 10 mm, and the loss of the bone by 2 mm has led into the distance be increased by 12 mm. So, in case if we are applying a force say about 200 grams, and it is multiplied by the distance from the center resistance, the net force will be 2000 grams per millimeter. But if the distance is increased, the force will be increased to 2400 grams per millimeter. Now this means where we needed the lesser amount of force, we are actually, because of the loss of the bone, we are with the same amount of force, we are applying more force, making it more deleterious. The bone will be subjected to increased forces and thereby more loss of bone. Hence, in such cases where there is periodontally compromised teeth, we have to reduce we cannot change the center resistance, the force application and distance with the center resistance. So we have to reduce the magnitude of the force. So we have to apply some lighter forces in these cases. Adult clinical management, periodontal consideration, gingival inflammation must be eliminated by acceptable oral hygiene measures and removal of the accretion on the teeth. The occlusion must be controlled during the period of stresses, such as severe bruxism, throughout the orthodontic treatment, so that the occlusal trauma and the tooth mobility will be prevented. Gingival tissue distinction should be made between thin, delicate gingival tissue and the normal or the thickened gingival tissue that is in the labiolingual plane. In addition, if the minimal zone of the attached gingiva exists, it is prudent to place a free gingival graft to help control the inflammation before the orthodontic treatment. Now, this is pre-orthodontic periodontal surgery which is needed. The prognosis of free gingival graft and the prevention of the bone loss is better if these are done before any recession has taken place. Osseous surgeries. As a rule, orthodontics should logically precede definitive osseous surgeries. The optimal approach: complete orthodontic treatment, establish a stable occlusion, wait for minimum for 6 months for stabilization of the bone around before a definitive periodontal procedures have been done. Inflammation control in the meantime is paradoxical. In a periodontally compromised adult, meticulously root surface planning, preparation, and curettage are performed In patients with a significant bone loss, furcation involvement, severe periodontal pockets, it may be necessary for the periodontist to do an open flap procedure. Gingival bleeding provides the most reliable index for determining the presence of the clinically significant gingivitis, and before placement of appliances, no significant bleeding should occur on gentle probing. Periodontal preparation of the occlusal management during the active therapy. This is achieved by root planning, root polishing, and curettage. Let us make it other way around: curettage, root planning, and tooth polishing. Throughout the tooth movement are frequently necessary to keep the periodontium free from significant inflammation. Frequency of the visit during the tooth movement will be determined not by the orthodontic adjustment, but by necessary to control the soft tissue inflammation during the appliance therapy. Control of occlusion. There are three ways to control the occlusion forces during the appliance therapy in adult orthodontic cases. First is disarticulation or disocclusion of the teeth to be moved, selective grinding, modification of mechanotherapy, that is by applying going for a lighter forces, milder forces. Conclusion: the increasing number of adults are willing to accept orthodontic treatment. Many adults may benefit from the adjunctive orthodontic treatment, that in conjunction with the restorative and the periodontal procedures, restore function and improve aesthetics. Adult age is no contraindication for orthodontic treatment. In nutshell, orthodontics can contribute towards the optimal oral health, eliminate occlusal trauma, and prevent adverse periodontal conditions from developing, and improve the psychological well-being of the patient at any age. Thank you.